Jesse, is that you? Hello, Harshan, are you there? Hello, testing 1, 2. Okay.
No, I'm not Jesse.
Hi, how you doing? Welcome. I'm Dr. Bennett. Hello, Harshan, can you hear me? Okay, we start in 35 minutes.
Hmm?
Good day.
Hello.
Hello, welcome.
It's my honor.
Yeah, hi, you're a speaker, right?
Yes.
Yeah, I'm the host, John Bennett.
Okay. Hello, John.
Where are you from? Which part of
I'm
China?
from Beijing. I'm from Beijing,
Oh,
China.
Beijing. Okay.
Yes.
Okay, I gotta change my background here
Uh-huh.
to make it more. Do you like using video? Do you like using Zoom?
Yes. Can I have a test drive for my presentation?
Yeah, sure. Let's do it right now. That's a
Okay.
good
Okay,
idea.
just a minute.
Yeah, it's a good. Hey, Michael.
Okay, now.
Well, Michael, I gotta let you in so you can talk.
Just a minute. Let me share my
Yeah, okay.
screen.
Hey, Mike,
Hi, everyone.
how you doing?
Good.
We're just testing out Dr. Chen's PowerPoint. Go ahead, Doctor.
Yes. I'm starting it now.
Okay,
it's a
yeah,
little bit slow.
you know how to start it, right?
Yes, exactly.
Okay.
No
Okay,
problem.
give it a shot.
Just a minute.
Yeah, okay.
Maybe Michael can test his presentation first.
Oh, go ahead, Mike. You want to test it?
Okay. Good.
There you go. Okay.
Looks good.
He's got it. He's a pro, right?
Yeah, I've done plenty of this.
You've done a few.
Okay. Now,
Yeah, the first step is click the share screen button at the bottom. That's the first
Okay.
step. You have Windows, right?
Yes, I'm using Windows. But
Okay.
I can. Here's a problem. Is that because you are not, John? Could you please check if I'm in the presentation faculty, in the faculty part or in the guest part? I cannot find any share screen button here.
Oh, really? Okay. Well, wait till Ben gets here. Ben and Liu, they can help lead you through. Okay?
No,
Because
there's
you
no.
should have if you have the latest version of Zoom, or actually the latest version of Zoom, that option should be there at the bottom of your screen.
Yeah, John,
Okay.
he's listed as an attendee on my list. Might need to be promoted.
Okay, sure, no problem. Just a minute. I will change a Mac to do that. Sure, that should be no problem. Just a minute.
Michael, are you in China now?
No, I'm in Hawaii.
Oh.
So it's like, that's why I was like, it's the middle of the night here. So I just want, if I was the second speaker, I was going to get up second.
Yeah, I was confused when you mentioned that the times. I said, well, wait a minute.
Yeah. It's the middle of the night here. But
Are you in
so
Oahu or Maui?
I'm literally at Waikiki Beach. So
Oh, okay.
that's what's in the background is actually the Pacific Ocean. So
Yeah, my brother lives in Maui.
yeah, I was just there earlier in the week for a meeting. So
A lot of conferences there. When he went there, we thought he'd spend a year, but he's been there like 20 years now. He likes it. He literally, I mean, you're really far from everything there.
Oh, yeah, it's true.
Yeah, you're isolated.
But the one thing that struck me is that all the hotels here have a building style that shows they were built about the 1980s. So they've had a big building boom. They haven't updated the architecture, so it's kind of interesting. So they really are kind of living in a different planet.
Mike, can you get your camera? Your camera's not on for some reason. I'm not seeing you. Oh, there you go. There you go. So you're in the hotel?
Well, I'm outside, yeah, because my wife and kid are sleeping inside.
Okay.
That's
so
why
how's it going? With the business, you're a businessman more or less now, right?
Yeah, I think it's going well. Yeah. We're making progress.
Good. Yeah, you have a lot of vids on the internet.
Oh yeah, we're working pretty hard.
Ever go back to Oklahoma? So that's memory.
I was just there about a month ago.
Oh, okay.
Parents and that kind of stuff.
That's where your home is, right? I mean, original.
Yeah, that's where I grew up. Yeah.
That's
Yeah, my parents still live. My parents still live there, so I wouldn't spend 2 weeks there just working out of their house and stuff.
Well, Leon Russell, that's the one person I know from Oklahoma. The singer Leon Russell.
Yeah, I don't know him personally.
No, okay. Yeah, he wasn't a really big guy, but he was from Tulsa.
Well, yeah.
He always
Yeah,
talked about it.
Yeah, they do have a fair number of country. I mean, Garth Brooks is from there. He's pretty famous.
No, he's not a country singer. It's I'm sure everyone's country around there.
Well, no, Garth Brooks is a country singer, yeah.
But he left. He went to LA early.
Yeah. Yeah, there's a few people. You know, in Oklahoma, you grew up, and the people who are famous, everyone knows who they are in Oklahoma. Outside of Oklahoma, hit and miss, but everyone knows who the famous Oklahomans are.
Now, are you in Hawaii for vacation or conference?
There was a meeting here, and so I went to the meeting, and then afterwards, my wife had never been, so we went around and saw a few places.
Oh, okay.
We're going back in tomorrow, so.
First time in Hawaii?
Second time for me.
Yeah. No, my brother tried to get me to live there, but you're too far from everything.
Well, I mean, it's not like you're not living in the middle of like, upstate New York or someplace.
No. You're far from civilization.
Yeah.
And he actually thought that a lot of family would come visit him, but it's such a big trip that not many people have gone.
Yeah, well, it's relatively like, I mean, if you're in Australia, you're a lot further away. You're 10 hours from Hawaii. So.
Good morning, Ben.
Hello, John. Hello, Michael.
Hi.
Hi, how are you?
Have you guys met each other before?
No, first time.
Oh, okay.
I've seen Ben's picture about 900 times, but I've never actually met him.
How many bypasses today?
Today is Sunday, just 2.
Oh, that's right. Yeah, that's right. Okay.
Just 2.
Yeah. Yesterday I have 8 kids. Yeah.
Wow.
Imagine that, Mike. Well, you can imagine. That's high-powered stuff.
Yeah. I don't do bypasses, but I have taken out 12 brain tumors in a day, but that's not the same as doing a bypass.
Yeah, not every neurosurgeon does bypasses, right? So
yeah, you either do it or you don't.
Your big area was minimally invasive gliomas, right, Mike?
Yeah, well, I kind of do anything that involved a tumor, but that was kind of what I like to do. Was
So Michael, your your topic is network-based neurosurgery.
Correct.
Yeah. Okay.
Yeah, I'll introduce you, Ben, and then you introduce Mike, okay? Okay, Ben?
Mhm.
I'll introduce you and then you can
Okay,
introduce
okay.
Mike, okay?
Okay,
Or do you want me
okay.
to introduce him?
Mhm.
Whatever you want. What do you want to do, Ben?
Okay.
Oh, okay, we'll do it that one.
Hello,
Yeah,
John.
Yeah, okay,
Thank
you
you.
want to try it? You want to try it?
No, you must have put me into the guest member part.
Oh, okay, let
Because
me check here. That's
Please put me into
possible.
the faculty part.
Okay. It's gonna ask you if you want to come in to the webcast, of
Yes,
course.
yes.
Yeah, okay, there you go. Okay, maybe it'll be different now. Check your screen.
Yeah. Shall I?
Yeah,
Okay, now.
there he is. Okay.
Hello.
Can you help him? Can you walk him through, Ben, about the screen sharing?
Okay, sure. I will try. Can you see my screen now?
Yes, we can see it.
Right? And this is the first case of our baby. Can you hear the sound?
We can
Yeah.
hear that.
Yes, we
Okay,
can
no
hear.
problem.
Yeah.
Okay, thank you.
You know how to put it in full screen, right? The presentation?
Yes, sure, no problem.
Okay. Okay, very good.
Thank you.
Thanks for coming. Yeah, that's why it didn't work, because I didn't have you in the camp.
So, Michael, is your topic similar with Professor Chen Xiaolei's? Because your
It's,
network, what kind of network do you need?
brain network. It's like anatomy, internal brain networks.
Okay,
It's
okay,
the organization of the cerebral cortex, basically.
okay.
徐教授好。
徐教授，陈教授好。
A lot of the stuff I'm talking about.
袁立中，
哎，袁立，
Wan Li, how you doing, Wan Li?
Yeah, sorry, I'm kind of late, but yeah, I just
No, you're not late,
fly from Beijing to Kunming, so yeah.
Oh,
Are you
you're on
stay in Kunming?
No, I'm in Kunming. Yes, yeah,
Okay.
because you know we are building a new hospital here as a part of the national center, just as your hospital in Fujian. Yeah, so. Great. Okay.
So, Michael,
Hey,
can
how you
you
doing?
turn on your light because it looks
Yeah, hi.
very.
Yeah, this is actually the.
Yeah.
I'm
Yeah,
actually.
You know, you just follow the link. The link's in there.
So yeah, this is actually as bright as I get. I can try to.
Okay.
Yeah, because it's 2 a.m. here, and my wife and this is a hotel, and so my wife
Okay,
and kid are
okay.
inside. Yeah.
Okay.
So this is I'm out on the balcony. What you're hearing in the background is the Pacific Ocean. I'm in Hawaii.
Okay.
Okay, call me. Can you call me in about an hour? Call me in an hour, okay? Yeah, don't worry about it. Do what you have to do. That's okay. We'll cover it.
Yes, that's about as good as I get. That actually looks kind
Okay.
of scary.
No. It's
Okay. Okay, thanks. No problem. Take care of business. Thank you. Michael, you know Warlicks, right?
Yeah, I saw her a couple weeks ago.
Yeah, okay. Warlicks, you're gonna introduce everybody. Hi, I'm Warlicks from Neurosurgical TV. Even though
John, I would like to, but I have a case. I have a meeting, but I just want to say hi to Mike. I met him actually in Thailand. Yes, and we talked, and he talked about like his project is really exciting, and I read the article that he sent me, and I'm start to work on illustration. That's
Are you
very-
staying? Are you staying and introducing things, starting things?
I did not prepare.
Okay, we'll
Yeah.
just say hi, I'm from Neurosurgical TV, and then introduce Ben. Ben will introduce Mike, okay?
Okay,
Okay.
sure.
Okay, you ready to start?
Okay, show time now.
No, not, oh, I'll tell you, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hi, welcome to the Neurosurgical TV today. Today we have a Neurosurgical Grand Round China, in which today we have a very interesting speakers today. But first of all, I would like to introduce Dr. Bin Su. He is the very talented neurovascular surgeon. So today he's going to tell us like the speaker details. Okay, so it's on yours.
Okay, so thank you, Warrocks. So let's welcome the first speaker, Professor Michael Sughrue, and his topic is network-based neurosurgery. Michael was finished his residence in Oklahoma. Now he works in Sydney.
Yep,
Okay,
that's
Michael, time is yours.
So what I'm going to talk to you guys about is about what we call network-based neurosurgery, which is mysterious enough to have been mysterious to people who are experts who are on the call now. But we'll define what that means, why we're excited about it, and apologize in advance that my camera is dark. It's just I happen to be on a hotel balcony in Hawaii. So what we're really getting at is when we cut the cerebral cortex, we do surgery in the brain. What we're trying to do is to make cuts where the lesion on the left turns into the hole on the right with as few problems as possible. And so when we're talking about things like gliomas, we know that tumors like this infiltrate the brain. In fact, the cancer cells integrate into synapses. So even if there's pure tumor at parts of the lesion, at some point, you have to cut into the brain to remove this. It's just fundamentally part of this process. And anytime we cut into the brain, there's a risk we're cutting axons and that those axons matter. So we have a pretty good understanding of how to avoid speech and motor deficits. We can't always accomplish that, but most of the time we can with existing techniques. But what we're not so good at is cognitive problems and just preserving the cognitive networks of the brain. And the reason in part is because we don't know how they're organized. So when I was at UCSF doing my residency, I was taught that there were not eloquent versus non-eloquent parts of the brain, and your job was to stay in the non-eloquent parts of the brain and don't cut the corticospinal tract. That was a tract that everyone knew was important. But the challenge with it is we know that the more aggressive you are with any lesion, the more likely you are to get a deficit. A good quote is 95% of the complications happen in the last 5% of the tumor. It's just kind of true of everything. But the challenge with it is, if we also say that, hey, listen, we don't want to get neurological deficits, we actually aren't accomplishing the goals of the treatment that we're trying to perform. And this balance is known as the Onco-Functional Balance, which is the idea that the more aggressive you are, the better you are at achieving goals of the surgery, but the more likely you are to get risk. And basically, there is no one right answer for everyone. So you look at the tumor on the left, going out and being cautious with this tumor to avoid a deficit is unrealistic. This is a very bad cancer, and without removing it aggressively, patients' neurological deficits you're worried about are the least of their problems. They're going to be dead. On the other hand, if you look at the patient on the right, if we are super aggressive here to get 1% more of the tumor and we remove the internal capsule, this is also not a good trade-off. And so we need to have rational ways that we make these decisions. Now, Over time, people have started to become more bold and talk about what's called supramaximal resection, which means to go into the normal brain to resect a margin. And this is, not surprisingly, has a small survival benefit. And it's not surprising because all cancers benefit from having margins taken. The challenge with it is that we never get really truly negative margins. And if you look, actually, I've been talking about supramaximal resection for over a decade. So I'm not necessarily against the idea, but I do think we have to ask, what is the margin we're taking? Is it the motor cortex? Is it the brainstem? And is it worth getting a margin with a small survival benefit at the cost of leaving the person a different human being? And even right now, when we are not taking a margin, our results aren't as good as we think we're going to. So many times patients are moving all forward talking, but they have depression or personality or cognitive changes that are very debilitating. So if you look on the right, this is a paper we recently published with some people at Penn State. And what you can see is that people undergoing surgery for gliomas have a 70% rate of new mental or worsened mental illnesses. Now, if we wanted to drop someone's quality of life, causing depression is one of the best ways to do it. In fact, it actually drops your quality of life more than causing a paralysis. And more importantly, we know that this is far in excess of other cancers. So people aren't depressed because they have a glioma. They're mostly depressed because they have a change in their brain, how it works. Now, we talked a lot about how do we think through this. And tractography has been with us since the 1980s. And awake mapping has been with us since the 1950s. And we haven't really come very far in improving our ability to avoid cognitive problems. Part of the reason is what I would argue is tractography and the use of tractography are only as good as our understanding of the anatomy that we're actually trying to observe. So if we look at all these fiber bundles, which one of these twigs is cognition, which is motor, which is speech? And without understanding that, this diagram, the tractography, is telling us that everything is off limits. That's not true. There's definitely some of those that can be cut and other ones that cannot. What we know from neuroscience is that the way the brain's functions are organized is in terms of networks, which are areas of the brain that are not directly next to each other that need to be talking to each other in order for the function to happen. So the most famous network is the language network. You can see Broca, Wernicke, and a few other areas of the SMA are in this network, but there are lots of other networks. So we know that the brain works in terms of networks from studies from EEG, fMRI, MEG, etc., where we know that areas of the brain that are not directly next to each other have highly synchronized activity. And so if you take the whole brain, it turns out that all parts of the brain are basically part of at least one large mega network, or I call them network axes. So if we take all the brain and divide it by its functions, you have the sensory motor axis, the visual axis, the limbic, but also networks that we haven't really thought of in neurosurgery, the central executive, the default mode, the salience, and the dorsal attention. Now, let's say we divide this further. Well, it turns out that some of these networks can be split. So the sensory motor can be split into two, the visual system can be split into four, and networks like the default mode network on the left can be also split into four. So for example, the language system is part of the default mode network axis, but it's closer to itself than it is to the core. And so when you get into the literature on this, when I first started studying this many years ago, it's extremely confusing. So we spent many years trying to get all of this into a single, simple framework so that we're all talking about the same thing. Now, what I'm going to argue is that saving network anatomy is important because networks are the organizing principle of the brain. And so when we destroy networks, we destroy the brain. So as you can see in the difference between the left and the right is that some of these axes, for example, if you look at the red axis on the left, notice that it can be split into the red areas, which are the language areas, and the yellow areas, which are the DMN core. And so this is actually a lot more useful. When we get to about 17 networks, we can always divide it down even further, all the way down to 180 80 networks per hemisphere. But that's also not very useful clinically. We can't really work at that level. But what we can do is, again, find core networks, CN core, default mode network core, and language. We can look at the dorsal attention and salience, but also there are also these subnetworks, multiple demand, ventral attention. Notice that the arm and leg are different network than the face, and the auditory network is different than the other one. That the default mode network has a memory area. Now, that's very daunting. And what it's saying is that everything is part of a network. So how can we do brain surgery if that's true? We know that we can cut into the brain, and not everyone is maimed or hurt from that. So what we try to say is, what are the networks that are important? And we have studied this quite a bit. And what I would say the best advice I can give everyone is to think about cognition as part of the big 5 networks, which are the default mode, salience, and CEN core, and the dorsal and ventral attention network. Now, again, I'll explain why we picked that, but let's just cover where these networks live. So the first is, if you think about the motor system, we spent a lot of time thinking about the motor cortex, but we haven't thought about the fact that if the motor cortex isn't connected to anything, it doesn't work. And in order to have motor function, you have to have other parts of the brain that plan movement, that talk to the motor system. Now, if we start looking at areas like limbic, notice that the limbic system extends beyond just the hippocampus to the parahippocampal regions and the orbitofrontal cortex. Also notice that this entire network was mapped using artificial intelligence, which is probably the way we're going to be identifying these networks going forward. It's important to note that the language network is far more complicated than we thought. So while it still has Broca's area, that's 44, 45, and then the lower right, you have the Wernicke areas. There's a couple of them. But it also has areas like that, which you can see on the upper left, 55B, which is a newly discovered speech area in the middle frontal gyrus that serves as a motor cortex for the larynx. Now, as we begin to look at the core cognitive networks, you have the default mode network. It's basically what happens, what's activated when you think to yourself. So when you're in your own thoughts, this is where that's happening. It has a posterior cingulate, an anterior cingulate, and a lateral parietal component. And damage to the DMN causes numerous problems, including most mental illnesses, but also several other problems I'll talk about in a second. The salience network is the switch that turns off the DMN and turns on the active networks like the central executive network, or CEN. It's a middle cingulate and anterior insula network. And the central executive network is a multi-part frontal and parietal network that looks sort of like this. It has the frontal pole, a prefrontal area called 8C, and a parietal area in the supramarginal gyrus. And it's really the difference between being 13 and 30. It's the maturity, judgment, and executive control network. The dorsal attention network has the frontal eye fields, the interparietal sulcus, and the lateral visual system. It really is part of holding your eyes and attention on a task. And when you damage it, not surprisingly, people's IQ drops because they can't focus on a task. So it has lots of consequences. It also runs out of the motor cortex. And if we extend our resection into the deep white matter, this is usually what we're cutting when we do motor cortex tumors. And the ventral attention network is probably the neglect system. Now, earlier I said that the networks are the organizing principle of the human brain. So I'm going to prove that to you with some work that we've done over the last couple of months. So if you look at this network, it looks very random and confusing. But what you can see is that not only is this the organizing principle of the cerebrum, it's also of the basal ganglia. In fact, we think about the basal ganglia as motor, but only that little turquoise part at the very bottom. If you look in the very bottom row, you can see the kind of blue turquoise. That's the only part of the putamen and caudate that are motor. The rest of them are cognitive. You look at the cerebellum, same thing. Only the blue-green areas are motor. If you look at the rest of it, it's cognitive. Now this seems very random, and it's not. And the first thing, if you look on the right, you can see that there's this kind of repetitive subunit. That argues segmental patterning, sort of like we see throughout the spinal cord. And we know that the spinal cord and the cerebrum come from the same structure. And so I became very interested in this when someone pointed this out to me, that figuring out, could we identify a segmental patterning in the cerebrum and understand why the networks were where they were. You can also see that this sort of triad, brown, which is CEN core, yellow, which is DMN core, and red, which is language. You see it here, you see it there, you see it there, and you see part of it there. So why is that repeatedly that way? In fact, there's no way, there's no place in the brain where that's not the case, at least in the lateral hemisphere. You also see it in the cerebellum, and you see it in the basal ganglia. So why do these triads happen over and over again? Well, to answer this, we went and tried to go back to this stage in embryology, which is consistent across mammals. In order to do that, this allows us to see a neural tube as a tube. We need to roll back time. So we have to unfold the brain the way it folded. Now, we all know that the temporal lobe makes a C shape, but how does it do it? And this is something that most of us haven't really gone and done mentally. But if you look at the lemma insula, essentially the temporal lobe needs to be flipped upside down. And the reason we know that is if you compare the human hippocampus on the left to the rodent hippocampus on the right, the rodent one is upside down relative to the human. Right there. So we know that it has to be flipped upside down. So we went about doing that. You can see we flattened it out, but more importantly, we put everything in its correct orientation back to when the brain was a tube. And we started looking at the networks. So if you look at this, look at the middle of this being the motor strip. So this is almost like a spinal segment. The segment below is purple, green, purple. That's salience, dorsal attention network, salience. It's a mirror image on the other side. You see these two networks, also mirror image. You have the visual system and the auditory system. So what about the triads? Well, it turns out that the triads repeat over and over again along this line. And the question is, why do they do that? So in order to answer that, we took the cytoarchitecture atlases of every animal that we could find, so all the way back to fish, and we matched everything up. We wanted to say that if two areas had the same cytoarchitecture that were in the same basic place, they probably were part of the same network. It turns out that that's basically a safe assumption. So we took the macaque and made a human-like atlas like this, and then we can directly compare them. What you can see is that humans have two triads that were added on to monkeys. One in the front, which is in the frontal lobe at the bottom, and one in the back in the temporal pole. And if you look at cats, they have no triads. So ultimately, if you think that removing the frontal lobe has no consequences, know that that's the entire evolution of primates was developing these triads. Now, if you put this neural tube into its position, it looks sort of like this. And we know that that corticospinal tract needs to be basically angled like this. So when you do this, all the white matter bundles, the cingulum, IFOF, uncinate, they become straight. They're basically intersegmental spinal bundles. That's how they're working, same with the arcuate. They all become basically relatively straight. If we put this in the alignment with the basal ganglia, you notice that this becomes very not random. You can trace all of this. So that's why the basal ganglia looks like what it does. You have to go back to where it was in embryology. And if you look at the cerebellum, the same is true. So just follow the numbers. You can see that without any doubt, cerebellum is tracing the frontal lobe, the prefrontal lobe. Now, if you look at this, that triad that is small in macaques but doesn't exist, it does exist. That triad is normal in macaques. That triad doesn't exist, and that triad doesn't exist. So if you look at executive function and semantic function, humans have it, monkeys don't. And the monkey emotional triad is the frontal pole. Now, when we were doing this work, someone published a paper in Cell showing that essentially that is exactly the way monkeys are organized. They had monkeys sit in scanners. So why should we save networks? Because they're the organizing principle of the brain. If the evolution went to this level to make these networks look like what they do with such a logical pattern, there's probably a reason. They're probably explaining the function and organization of the cerebral cortex. And while we don't have randomized trials proving this, we're starting to have increasing data showing that it's useful to do this. And we don't have randomized trials showing that cutting the optic nerve and spinal cord are bad. It's just, we know that they are. And so when we start looking at the big 5 networks, the reason we put this is these are the core of the triads, the core of the organizing principle of the brain. And we know that they cover a lot of the cognitive footprint. A lot of it's linked to the core of these networks, which tell other networks what to do. Now, should neurosurgeons save these? Well, again, we did a meta-analysis covering 22,000 papers. I actually did this myself initially. You can see that over 550 papers published in the last 10 years show that destroying or damaging or causing problems in these networks causes a cognitive, emotional, neurologic symptom. We also know that networks can provide explanations for things that we haven't totally understood. So we know that injury to the medial frontal lobe can cause a kinetic mutism, which is a very bad problem. But why? Because if we have tumors in this area, we have to know what we're trying to not cut. Well, it turns out that if you look at the supplementary motor area, injury to the supplementary motor area is an initiation problem. And at least half of the SMA is part of the salient network. So the salient network turns off the DMN, where you think to yourself, and turns on the active systems, the SMA problem. And if you look at this, this isn't just an interesting anatomic diagram. This is a paper from PNAS where they show that the lesion that cause akinetic mutism are in this little axis, the initiation system. We utilize this data in our own cohort. You can see that these are tumors in and around the medial frontal lobe SMA. And what we demonstrated is if you preserve the integrity of this system and the frontal asinine tract, SMA syndrome just doesn't happen, or it happens very, very mildly and very limited. Whereas when you, before we understood this anatomy, we had a 47% rate of causing SMA syndrome, sometimes permanently. Our number is very similar to what's seen in the literature. Another more recent study was done by Michael Lawton's group at Barrow. While this has been published yet, what it's basically showing is they looked at 364 cavernous malformations, looked at the trajectories that people were taking, and found that going through a network, one of the big 5 networks, had a very high rate of causing decline in modified Rankin score. So this isn't subtle cognitive problems, this is disability. So ultimately, this is actually data from China, from a group we're working with at Jiangsu's Peoples. And the thought is, how often are tumors around the insula involving the big 5 networks? It's not surprising that eloquent areas like the motor cortex, the language areas, are frequently close to the tumor. But the big 5 networks, there's always at least one close to the tumor. So inevitably, we've been cutting these networks for a very long time and not going over there. One of the challenges when we do surgery in the interaxial space is that it's deceptively simple. So we all know that skull-based surgery is difficult. I've done lots of it. And we know that it can take a long time, there's lots of risk, and the anatomy can be complex. But there's one advantage that skull-based surgeons have, which is that all of your anatomy is visible and known. So we know that we can see the nerves and could possibly preserve them. And we also know that it's very unlikely that next year someone will credibly identify a 13th cranial nerve that we didn't know about. What happens when we cut into the cerebral cortex is that the patient, we don't injure the carotid, we don't injure the brainstem, we don't have these really horrible complications. But what we do is frequently cut through the cognitive systems because we don't see them. Look here, this is actually right next to the default node in the case. We preserved this, but how would we have even known that we were there? And the reality is we have to frame our thinking better. And this is what I wrote this book for. And what we're really trying to do in the book was to think about how to make safe cuts around networks based on how we understand them. So we did this, and more importantly, it's one thing to say, hey, it's worth saving networks, but if you don't actually have the ability to put this on surgical guidance systems and find where they are in your patient next to the tumor, then we're not likely to save them. So what we wanted to do is to make an AI tool that could find the networks. So again, in order to do this, you have to be able to take a brain and atlas it, meaning that you say the Broca's area is here, the SMA is here, etc. The challenge is that most of my patients had brains that look like this, and if they've had surgery, it gets even more complicated. So what we did was we created an AI algorithm to handle this, and we handled it by diffusion tensor imaging. So we taught the machine learning how to look at a voxel and know whether or not it was part of Broca's area based on its connections. So you can see that that voxel belongs to Broca's area and this one does not. It's not talking to Wernicke's area. And so where it really excels is when it tries to put Broca's area to a tumor or a hole. And we know that it can't be there. So there are no tracks going there. So the machine learning knows to move that to a neighboring area. It's able to do it even in brains that look like this. So this is a patient that we removed the frontal lobe. You can see there's a huge recurrent glioblastoma. The insula is shifted forward, but yet it still knows where the basal ganglia is, what's missing, where everything's been moved around. So we built this into a tool. It's now available in the US, China, India, among many other countries. And what we basically did was make it as simple as possible. So everything's automated. You can see that this is the default mode network. Again, pulled out using artificial intelligence. There's no hand processing, anything like that. There's the salience network. And see, we can do much simpler things like the spinal tract. The goal is to put this on the image guidance so that we can see these either through standard image guidance, increasing the augmented reality, VR, etc. But more importantly, that we actually have this information integrated into our image guidance. So you can see over here, we can take these objects, put it onto things like BrainLab Stealth or Diagnostic. You can see that this is the language system. And it isn't just marking Broca's area or Wernicke's area. More importantly, it doesn't require anyone to do anything, it's just a standard DTI sequence. And as we've gotten experience with this, we've learned a lot. And one of the things we've learned is that this tumor needs to be operated on differently than we used to operate on it. So when I was doing residency, the way we were taught to do this tumor is you get the CUSA and you shave this down until you run into something bad. Well, there's a couple problems with it. The first problem is that how do you know you stopped in time? The second is you're doing the most dangerous part of the case when the brain is shifted and the image guidance is the worst. So you actually want to do the dangerous part first. And we want to basically go right at the area where we need to make a division and separate it out. With QuickTone, we can actually look at these networks and see that, guess what? They're around the tumor, not surprisingly. Central executive, default mode, and sensory motor system were threatened by this lesion. So we can then think about this as a series of cuts. And we do the cuts first, not last, because that's where we want the image guidance to be the best. So more importantly, when I give these talks, people have told me for years, well, hold on, you're going to be leaving tumor behind. And the answer is yes and no. What we are doing is we're sometimes leaving tumor in places like the basal ganglia. You can see that right there. If anyone, that's behind the M1 and where the lenticular striates enter the brain at the perforated substance. So while there may be somebody who goes after that, best of luck to you. I don't know if that's a trade-off. The second thing about it, you can also see this a little bit in the default mode as well. So this is not a biopsy. This is an aggressive resection. We're not doing biopsies. But what I would argue is that the survival benefit of improving your extensive resection by 2 to 3% is probably not worth absolutely destroying someone's cognition in the process. And anyone who ever has challenged me on it, I always say, well, do you remove the brainstem and thalamus? Because that's eventually there is a line. Everyone has a line. And so this is about determining what are the things that are important for quality of life and putting the line there. As people have done more cases, we find that sometimes the quick tone shows the tumors in the lesion. You can see, or the tumors in the network. So you can see here, the language system is draped all over this tumor. This tells us we need to be very careful and that we need to have a real discussion with the patient and family. Sometimes it shows us that the shortest path is the best. So this arrow was the path that the surgeon who was planning this case wanted to take. This was the shortest path to the tumor, but actually it's going to go through the language system of the dorsal attention. So you want to take a longer path to more brain. That's counterintuitive, but it led to a better outcome here. And most importantly, sometimes we see that the network is draped all over this. So if you look at this bad glioblastoma, the salience network is literally split in half by this, spread the fibers. And AI can find this, humans cannot. It can show us that the default mode network is already destroyed on one side. So we have to be very careful of the other side. And so, again, no surprises. It's one thing to cause a deficit, it's another to cause a deficit that you didn't know what you were doing. And this is where surgical adjuncts can be important. They can find that the salience network is actually still there, it's still connected. So it's savable, but it's very difficult. And so this is a good, important informed consent. But another thing networks can do is to help us fix the patient after surgery. So if we look at this case right here, this patient is very likely to have a deficit. Probably already have one when they come in. We may not be able to make it better. We know that patients with neurological deficits, irrespective of IDH1 status, irrespective of anything else, do worse from a survival standpoint than patients who don't. So getting patients to the highest level of function, it has a survival benefit. Now, there are tools to treat patients to improve their neurologic status. They've been around for 30 years, and they have very good track records. So if you look at transcranial magnetic stimulation, it's a paddle that has 2 coils of wire. It delivers a magnetic pulse through the skull into the brain, stimulating it as many as 150 times a second. And it induces the field you see here, now on the right. Now, even though a lot of the brain is getting a field, what's been shown by several groups is that that red area needs to basically be in the correct place. So it does matter where you treat. And more importantly, there's over 150 randomized controlled trials that show that side effects are minimal, and the outcomes are often very good. We can often make people better. And so we know that it can induce plasticity in the brain. And the big question is, how do we pick where the target is? Well, in order to understand where to aim this thing, and again, there are other adjuncts, focus ultrasound, TVCS, we can go on and on and on. There are other ways to do non-invasive rehabilitation. But no matter how you do it, you have to understand that function results from the wires, okay, and the function between those areas. So if either one of them is out, you lose function. So when we think through how brain injury happens, we put a hole in the brain, there's wires that are cut. But then, because every parts of the brain are connected to other parts of the brain, there are indirect effects where parts of the brain begin talking too much, that's in red, or too little, that's in blue. And oftentimes, this functional disconnectivity is the cause of the deficit. So what do I mean by that? So let's say we take a brain, and we look at how areas of the brain communicate at rest. So even if you and I are thinking about different things, while there are some areas that will engage in you that don't engage in me and vice versa, there's consistency in a lot of areas. We know that certain areas frequently talk to certain areas and don't talk to other areas. That's the whole concept of networks. And if we study this, we can put a number on it. We can say that these areas communicate a certain percentage of time, and that's normal or abnormal. Now, what we know with diseases like mental illness, Alzheimer's, and increasingly we've studied this in brain tumors and stroke, is that areas of the brain begin talking too much or too little. And this is an indirect effect of the damage. So you cut something, and it throws off the timing of other areas. If we map this in the whole brain, we can then flag these outliers and know where to aim the coil. So, for example, if you look here, this is a language system in a normal individual. You can see on the X and Y axis are lists of brain regions. Now, Broca's area is on here, a lot of other areas. Every square is a comparison of the firing of two areas. So Broca's area and Wernicke's area, Broca's area and the SMA, and every other combo. And notice that it's mostly red. Red means correlated, and networks are correlated. They fire together. That's why they're a network. If you look on the right, this is a patient with a glioblastoma destroying the arcuate fasciculus on the left side. And you can see that it's blue because those areas aren't communicating correctly. They're communicating too little. So we see aphasia. That's very interesting. But what's more interesting is the fact that that column is a place in the brain. That's telling you how area 55B that I mentioned earlier, the motor cortex to the larynx, how it's talking to other parts of the brain. So we can look at that column, say that that's that part of the brain. We can change how it works. We can flag it and say that these are not normal connectivity. We can even know where to look using artificial intelligence. All this is stuff that we've created. So in order to take a patient who's we've done surgery on and make them better, you have to first see the damage of what was cut out, and you have to see the functional disconnectivity. If the corticospinal tract's been cut, it is very unlikely that TMS is going to cause it to regrow. But more importantly, if it's not cut, and that's frequently the case, the functional disconnectivity can be corrected in a matter of hours. And sometimes these patients make recoveries that are that fast. We know that it's not from new wires regrowing. Again, we've been doing this for a while now. This is our early paper. You can see that these are people that we did a similar paradigm on. You look in the bottom left, these are the aphasia score, top left. These are the patient's aphasia scores going down. On the right, these are the motor functions going up, sometimes from 0.5 to 4+ out of 5 in a week. So this is very, very fast for any recovery. And in case you thought that this was a temporary thing, that the patients would recover on their own, the evidence shows that that's probably not true. So this is a randomized trial out of Germany, out of Munich by Sandra Krieg. And what they demonstrated is that patients undergoing TMS for motor weakness have a significant improvement that's lasting. They continue to diverge. You can see on the y-axis of this is Fugel-Meyer score. Higher is better. And you can see that the recovery is significantly better in the TMS group for people who have hemiparesis after clinical surgery. So again, looking at the structure and function to figure out how to treat the patient. Let's skip this for a second. So first, let's go through one case. So you can see that this is a patient with a cingulate gyrosglioma. This is the preoperative scan. You see it's very close to the motor system, the corticospinal tract. And he underwent surgery by my partner. Now, you can see that he had a recurrence, and that recurrence is in the motor cortex. So after a discussion with the patient, he said he wanted to be as aggressive as possible. And we told him that if in the likely case that he would be paralyzed after the surgery, we could try to augment this with TMS. It might work, it might not. So he took us up on that. He wanted it out. So you can see immediately after surgery, this is the day after surgery, you can see that he's completely plegic in that leg. So in fact, he was plegic for a week after the surgery. In that leg. So here she's telling him to imagine moving his foot because he can't move it. You can see this is after 2 treatments. It's already, and again, he came in Monday morning with that function. So he's already started to regain function after 2 treatments. This is after 3 days. And this is after 5 days. So you can see there he is, he's practicing surfing. So he's got pretty good control. It may not be 100% normal, but the answer is this is an excellent recovery and it's very fast. And we did this without putting him at any major risk. So how we pick this is the following. So first we looked at the structure. You can see this is in our software. And what you can see is that what we want to know is the corticospinal tract cut, because this changes the entire discussion, right? CST cut different treatment, much worse prognosis, but it's there, still okay. So next question is, where is the functional disconnectivity? Because that's our hypothesis. So we're going to look at the motor cortex on both sides. So this is a correlation map on the actual brain. So you can see that yellow seed is in the motor cortex on the good side. You can see that really bright red. It's not normal. It's too connected. So that happens frequently. When you injure one side, the good side becomes overactive. And so we want to turn that down. And there are pulses that will be inhibitory that can decrease the activity of that area. The other thing we can do is look at the bad side. So this is the bad side. If you look at blue, that's the SMA. So the motor cortex isn't talking to the SMA. Don't know why, just isn't. So we can stimulate the SMA and try to put this back in sync. We did this in combination with rehab, and so we got a result. So the bottom line is that we can improve the cognitive and other outcomes of our patients by using intelligent decisions, using artificial intelligence, more importantly, thinking in terms of networks in ways that can actually dramatically change our ability to push the boundaries.
Wow, great. Thank you, Michael. I have to say thank you very much for your very informative presentation. And also thank you, John. You recommended Michael. And we are very, I think we can invite Michael for a serious presentation for his, you have a book already published, a book. I think
Yeah.
a lot of content. Yeah.
Absolutely.
Yeah, I'd love to.
Yeah,
There's
yeah,
another
yeah.
one. Yeah, sure.
Yeah. Great presentation. Thank you. Thank you so much. I learned a lot. Yeah. Yuan Li.
Yes, actually, yeah. We are also very interesting for the so-called network, brain network in neurosurgery, and now we. I think that I fully agree with should be Dr. Xu that Michael, you give us a very wonderful lecture focused on this topic, and I think I want to know a little bit more about the how to actually how you what kind of special technique you use to to understand the whole so-called connectome structure in the brain. So is that only we MR special MR sequence or some combined with some other technique?
So when we built our software, we wanted this to be able to be done anywhere. So any reasonably modern MRI. So we do everything with DTI, and it's a very simple DTI sequence. So everyone's scanner will do this. What we then did is we use AI to find the areas, and then when we know where the Broca's area is, we know what Broca's area does, and it is so. What we leverage is the fact that we know an enormous amount about a lot of these areas, and we bring that information into the software into very smart ways. So I've been studying the HCP Atlas for pretty much since it came out, almost the week it came out, I started studying it. So about 6.5 years now. And I published an entire issue of Neurosurgery back in 2018, just talking about what these areas were, where they do, and then we've been mapping them ever since. So we don't know everything about what every part of the brain does, but we know a lot more than we did 10 years ago. It's not comparable. And so what we do is we take all that information and we put it into a software that makes it very, very easy. So if people are interested, I'm happy to dive deeper on it, or we can do trial cases and just show people what it's like. But we made it pretty much almost anywhere you can get the scan. It's very easy.
Okay.
Okay.
There is a question from Sylvia Sauer, right?
Yes.
Do you consider the cerebellum a very important center in cognitive network? sense?
Well, the evidence is overwhelming now that the majority of the and it's not just the paper I just showed you, there's lots of evidence on it. The majority of the cerebellum is part of the default mode, central executive, and other types of networks, and not the motor system. There's a percentage of it that's motor. It tends to be in the vermis and the anterior lobe, but the majority of the hemisphere is cognitive. So we know that. What we don't know, because it hasn't been well documented, which is, does it affect things? You know, if I cut the cerebral hemisphere, obviously, if I remove it or I get into the deep nuclei, we know for sure that it causes more than just motor. It's pretty bad. But if I make this cut in the lateral hemisphere, is there a deficit that anyone can find? And maybe not, right? I mean, I haven't noticed the patients with lateral hemisphere meds that I cut into have that problem. But also, we're not doing cognitive testing on this. So we really need to probably think a little bit harder about this question. But we know for sure that the hemisphere, the majority of it is not participating in motor function, or at least not in that typical sense. It's involved in something much more sophisticated in that sense. But what we don't know is what's the clinical consequence. So as I pointed out, if we designed our software in a way that we said everything is eloquent, we can't do surgery, right? But we know that we can, right? Can't throw out everything we know about brain surgery because we need to learn new things. What we know though is that there's some areas that over and over again keep showing up on lists of this has consequences. So I wrote a paper about the default mode network in 2016 in Journal of Neurosurgery. In the Barrow paper, they replicated something very similar, which is if you cut through it, 70% of people, even on one side, it's not well tolerated. And if you cut it on both sides, it's not tolerated anyway. So it's a very important part of your brain because it's your thoughts, it's your cognitive workspace. So these patients don't have a hemiplegia, they just are, in many cases, they're much worse off than patients who have a hemiplegia.
Takashi, would you like to make a comment? Takashi is a brain tumor man from Tokyo.
Thank you, Dr. Sughrue. I'm Dr. Takashi Kon from Tokyo, Japan. I've heard your lecture in last December in the Brain Tumor Society in Japan. Very informative lecture, and about the neural network, very informative. We have to learn more. So I expect more detailed network on the right side, right hemisphere, in dominant hemisphere and brainstem network and hypothalamus. So we're expecting the neural network and neural fibers. So we are checking your papers and studying your papers. And further, I expect the further development of your study. Thank you so much.
Yeah, so we're actually doing the right hemisphere this year. Actually, we've been diving into it. I'll give you, we're still, in many cases, when you start getting into these kind of questions, there's an enormous amount of data you have to go through. So
yes,
there's some papers about the evolution of the connectome we have, where there's 500 slides that we've created just for that paper. So it's enormous amount of data. What I'll say that we know so far, one of the things we studied last year was judgment. We haven't published it yet, but where's judgment processing? What makes good judgment? And it turns out there's two types of judgment. There's moral judgment and there's episodic judgment. So moral judgment is doing good to others, being a nice person, don't do things to other people that you don't want done to yourself. And that is clearly in the default mode network on both sides. That it's pretty much most of that network. So the DMN is part of moral judgment. If you look at episodic judgment, which is the judgment that says I should go to bed because I have to get up early in the morning, like being an adult, right? That is the right CEN. It's mostly the frontal parts of it. So we thought about this right frontal pole as the safest place in the brain. Well, depends what you mean by safe. It's not totally safe. It's just dangerous in a different way. And anyone who's ever taken out the right frontal lobe knows this is a problem, right? It's just not paralysis. And so the reason for it is simple. And what's really fascinating about it is that there's a lot of evidence from other people, not my work, that what's developing in adolescence is the CEN. So your DMN is developed at an earlier age than the central executive node, for the most part. There's some exceptions. but the CN is what's really maturing in the adolescence and early adulthood. And of course, that makes sense because adolescents have a fully formed cognitive system, but they don't make good decisions all the time. And it makes sense, right? We now understand that. But then, of course, when you get down to it, if you destroy the frontal CEN system on the right side, you're basically taking someone back to teenagehood. And we know that if you've ever dealt with people who, the family can't handle them because of the right frontal injury, then you know that it's a lot more important than we thought. As far as it goes, when you study issues of laterality, it's extraordinarily complex, and we're still diving into the data. But that's actually something we're working on. Like I was looking at data last week. So
thank
stay
you.
tuned.
Thank you. Expectation for the studies.
Okay, very good. Okay, Michael, I think we'll wrap it up. Any closing comments at all from anybody?
No, thanks everyone.
Okay, thank you again, Michael. I think it's a very early morning in Hawaii. Okay, thank you.
All right, thanks, guys.
Yeah, thanks, Mike.
We will
Enjoy
invite
Hawaii.
you again. Yeah. Enjoy.
We'll see you again.
Okay.
Okay,
Okay.
Juan Lee, do you want to introduce Dr. Chen, please?
Okay, yeah. So today, the next speaker will be Dr. Xiaolei Chen. He's from the PRA General Hospital, and he's a very talented and smart young neurosurgery professor. And today, he will introduce actually his the new tactic designed by himself. It's called Mobile Internet-Based Mixed Reality Interactive Telecollaboration System for neuroendoscopic procedures. Dr. Chen, please.
Thank you, Chairman. Dear Chairman, dear faculty members, dear Professor Zhao and dear Professor Xu. Today, it is truly my honor to be here and share with you with our experiences for the developing of the mobile internet-based mixed reality interactive telecollaboration system for neurosurgical procedures. We call this system a MIMIT system. So as we know, it is well known that the unequal distribution of the medical resources is a big issue in China as well as in the other developing countries around the world. So the picture on the left side demonstrated that the number of medical centers or number of hospitals in China, we can see that most hospitals are located, or the number of the hospitals are located along the coastal sides or the east part of China are significantly higher than those located in the west part of China. The picture on the right side shows physicians every 1,000 people have in China. It is also the same. That's the number of the physicians that every 1,000 people have in China along the coast part or along the coastal provinces are significantly higher than those in the west part of China. That's a big issue. For example, in Xinjiang and the Xizang province in China, every 1,000 people can have maybe less than 2 physicians. It is there's a big gap between the west part and the east part of China. And I am now working in South Xinjiang, in Hetian, which is a small oasis in the great Taklamakan Desert in Xinjiang. So you see, it's here. So in the satellite map, you can see all around this small oasis are grand desert. So it is a quite isolated part of China, and the medical resources are very, very limited in this part of China. So that's a big problem. But after our investigation in the Hetian, Xinjiang, we found that even for a county hospital which I now work in even in a small county hospital, the hardware is not a big issue. For example, we have a 1.5 Tesla MRI, high resolution CT, high definition endoscope, and operative microscope. On the other hand, the software and the the manpower, human resource is a big problem. For example, in the Department of Neurosurgery here, there are only 2 residents with very little relevant experiences before I came here. So the major issue, the main issue is not hardware, it's software and the lacking of the skilled neurosurgeons. So we developed this system several years ago, sort to overcome this kind of issue. We call it the internet-based telecollaboration. It's a mobile internet-based mixed reality interactive telecollaboration system. We use it for neurosurgical procedures, for example, the endoscopic procedures or the microscopic surgery. But theoretically, after my presentation, I want to convince you that this system is also suitable for other surgical procedures, as long as there's a video output through the procedure. You can use this system. So the diagram of the system is like this. First, the video signal from or the video output signal from the endoscope or microscope can be transferred into a local video processing station, which is called LVP station. After that, the video signal can be transferred to the cloud server, and followed by the observation of the remote instructor in another city or in another place. The instructor can observe the surgical procedure or the surgical video from either a PC or a handheld mobile device like iPhone, iPad, or Android mobile phone. And after that, the instructor can use finger gesture to mark on the surgical video. After that, the updated surgical video with the marks on it can be transferred back to the local site and displayed with a mixed reality device. Here we use HoloLens from Microsoft we developed a software for the display in this mixed reality device. And then in front of the local surgeon, there will be a virtual display panel floating in the air and display the surgical video with the marks from the instructor on it. So meanwhile, the local surgeon can also hear the voice command of the instructor in the remote site. So in this way, the 2 neurosurgeons, both the local surgeon and the instructor can cooperate or telecooperate in the same surgical session. So we developed the apps on mobile devices, both on iOS devices like an iPhone or iPad, and also for Android devices. So as long as everyone have a mobile device, you can install the apps and log in and accept the invitation of from the local surgeon for the telecollaboration and start to be the instructor. So it is very simple. And this is the picture of our first test. Our first test succeeded in 2017. And this is an endoscopic procedure. I am the local surgeon in this scenario, and I'm wearing the mixed reality device. And this is a virtual display panel, which floated in front of me during the surgical procedure. And this small picture is a picture of the instructor at the same time. The first test happened in the same building. I'm doing the surgery in the surgical theater, while the instructor is sitting in his office and using a PC to do the telecollaboration and perform the mark on the surgical video signal. So this is the first case of our MIMIT system. Hello, Dr. Ho. Where is the lesion? Well, the navigation is accurate. The hemosiderin deposit can be seen here. So the lesion is here. Could you please mark it? Can you see the mark? Yes, I see it. Which direction should we take? Okay, I will draw a path. So the instructor can also draw a path to demonstrate. Okay, I got it. Thank you. Okay. This case is endoscopic removal of a cavernous intraparenchymal cavernous malformation. So after that, the first part happened in Boston, USA. So this case is a case that our system has the longest working distance. It is between Boston, United States, to Jingzhou, Hubei. That happens in 2018. At that time, I'm working in Harvard University, Brigham Hospital. So in this case, I was the instructor in Boston, and Dr. Huaping Zhang was doing an endoscopic procedure in Jingzhou, Hubei, and we tested this telecollaboration. This case is endoscopic fenestration for a trapped temporal horn. Okay, now let me freeze the screen. I will draw a mark. This is a place to do the fenestration. It correlates well with the image simulated with virtual endoscopy. Please be careful here. Just a minute, I will change the color of the mark. Please avoid injury to this part, marked now by me with red color. It is the choroid plexus. Okay, now I'm going to unfreeze the screen, and please carry on. Now please use the fenestration forceps to do the fenestration. The following part happened at the same time in Jingzhou, China. Okay, now let me freeze the screen. I will draw a mark. This is a place to do the fenestration. It correlates well with the image simulated with virtual endoscopy. Okay. Please be careful here. Just a minute, I will change the color of the mark. Please avoid injury to this part, marked now by me with red color. It is the choroid plexus. Okay. So at that time, we have already fenestration forceps, please. So please use the fenestration forceps to do the fenestration. So at that time, we have already modified the software so that before the instructor makes marks on the surgical view, he can freeze the screen first and mix marks, and until the local surgeon understands the finger gesture or the marks, and then the instructor will unfreeze the screen so that the surgical procedure can continue. So it is now quite easy to be used, and after 2 years experiences with this MIMIT system, with the 4G mobile internet network, we converted or we started the work with a 5G high-speed mobile internet. So this is a first test, first mimic case with 5G mobile internet. It happens in 2019. At that time, we constructed 2 5G test sites, one in Beijing, the Chinese PRE General Hospital, the other in the Hainan campus of the Chinese PRE General Hospital in Sanya, Hainan province. And to prove the real video latency or the delay of the system, we also programmed one small application to see the real end-to-end time gap or time delay of the system. It works like this. First, on local side and the instructor side, both system, which are Windows system, are both Windows systems. First synchronize with the internet time, and then start our program, which is called milliseconds clock. And the clock will display the real system time to the millisecond level. And then we compare, we put the image of the local site as well as a remote instructor site picture aside, and then took 10 pictures, every 1 picture every minute, and then we calculate the average time delay of the gap displayed by our milliseconds clock. So in this time, in this case, we have the precise video delay end-to-end or user-to-user video delay data for every case. So we can see a dramatic decrease of the time of the video latency or the video delay when we use the 5G high-speed mobile internet. We will see the data here. You can see the completely we enrolled 20 cases in our study, and the first 16 cases were tested under the 4G mobile internet, while the latest 4 cases were tested with the 5G high-speed mobile internet. You can see the video delay here, the video latency is significantly lower in the case of 5G high-speed mobile internet. If we compare to the data when we use the 4G high-speed 4G mobile internet. So we are quite confident that with future fast development of the 5G internet in China, this system will have better data in the future. So the results are as follows. This is a distance. The longest distance is this case from Boston to Jingzhou, China, and the red dots indicated the video latency with 5G high-speed mobile internet. So to our knowledge, our study is the first reported interactive telecollaboration system for neurosurgery. And there's maybe in the future, there will be a possible transition between the traditional neurosurgery and the long-distance full robotic surgery. But so far, or in the near future, personally, I don't think the long-distance full robotic surgery is possible or safe enough for the neurosurgical procedures. So now our MIMIC system, all the neurosurgical procedures with or supported with a telecollaboration system will be a very good bridge or a good transition between these these two periods, which is traditional surgery and the full robotic surgery, because now it's not a neurosurgeon controlling a long distance robot to do the surgery. It's actually a very experienced neurosurgeon helping a local neurosurgeon who has already got basic training to do the neurosurgical surgery. It's a human helping a human, not a human control a robot. So it's safer and it's easier in the near future or in the present period of time. So another feature of our study is a real end-to-end latency test. As we have already mentioned, that we also developed a dedicated small program to test the real latency to the millisecond level. We believe there will be a bright future with the 5G development in China, and as well as in other countries in the world. And another feature of our study is we also developed one novel business model for this kind of system, because we know that if we want to make this system longer sustainable, we must have some kind of possible or feasible business model. We cannot support the system only with passion or love, right? So, but as long as we have a possible business model, the system can run and in a very healthy way. So if you are interested, you can check our paper describing this model in this study. It is our great honor that in 2019, the Prime Minister of China, Prime Minister Li Keqiang, inspected our project and gave a very important comment on this project. So we believe that in the future, maybe the more and more people will benefit from this system or from this technology, both for neurosurgeons or the patients. So our ongoing efforts are as follows. First, we want to build one smart online case or the mission recruitment and the distribution system. We adopted some successful experiences for the internet-based business like Uber or Facebook, this kind of a business company that we should have some kind of a smart online recruit and distribution system. And also we want to develop one online rating or comment system for both local neurosurgeons and remote instructors. Another issue that we should continue to working on is the reimbursement and liability problem or the issues of this system or of this technology. And finally, the most important thing is a rigorous assessment of the impact on the patient outcomes of this system, because the main purpose or the goal of our system is always focused on the better patient outcomes. How the conclusions are as follows. First, the BIMS system allows for real-time, long-distance telecollaborative neuroendoscopic procedures and surgical training through a commercially available and inexpensive system. The second is it enables remote experts to implant real-time, long-distance intraoperative interaction to guide inexperienced local surgeons. But we admit that the local surgeons at least has already got the basic neurosurgical training or endoscopic procedure training. And it may help to redistributing excellent or good medical resources in China as well as in other developing countries. So our study has already been published in Neurosurgical Focus this this June. So if you are interested, you can check our paper and try to find the technical details in it. Finally, I want to thank our team, the first author of this study of this paper, Dr. Zhang, and the appearance can be deceiving, right? He dressed like a Gambia member, but actually he's a neurosurgeon. So these are our good fellows in our team, and our team name is a Tactical Neurosurgical Team, which is AKA TNT team. So we are still recruiting members. If you are interested, you can contact me. So thank you very much for this great opportunity, and thank you for listening. Thank you.
Thank you, Sughrue. I think it's also a very interesting topic. It's kind of a remote control long robotic system from a long distance, right?
Yes.
So yeah, it's kind of so now you actually with this technique, I think you can do surgery. I mean, for the patient everywhere from your center, right?
Yes. Yeah. Exactly. Theoretically.
Oh, yeah, interesting. So, is there any I mean, special protocol like for the network? I mean, security. Like, I mean.
Yes, that's a very, very important comment or very important question. So this is also the network or internet safety issue is the thing that we are mainly focused on in the present period. So far, the safety is just like any other internet business, like the Uber or the Facebook, this kind of thing. So we do know that the medical use has a high level request of the full safety than the routine daily issue. So this is the thing that we should continue to work on. Thank you.
Mm-hmm. Okay. Yes. Are there any other questions? So do you think if you can also use technique for some more complicated, I mean, surgery?
Yes, it's possible. As I have said, as I have mentioned, that as long as you have video signal output, for example, from a surgical microscope or endoscope or other thing, you can use this MIMIC system to do the intraoperative telecollaboration. And we, before our system, the traditional way, I believe Yuan Li that's also has similar experiences. For example, people use WeChat to call you and to ask you to help him to tell him where is the lesion or where is the aneurysm. How can you apply the aneurysm clip? You do have this kind of experience, but at that time, you only use the voice commands, right? You can only ask him left a little bit more left or right or to the northeast corner, this kind of thing, right? So we are actually have the inspiration from Steve Jobs. You know the great genius Steve Jobs used to make an example. For example, if you want to point that here in my shirt, here this part, there's a sting here. There's a spot here. If you use language, it has very it takes a very long time to explain. You can see just left to your first button of your shirt, 1 centimeter left or 2 centimeter left, there's a spot there. But Steve Jobs said, if you use the finger gesture, you just point here, just here, there's a spot. It is very efficient. So we are inspired by the Steve Jobs that if we can directly make a mark on the surgical video and then transfer the surgical video back to the surgeon, to the operator, he can directly see where he should go or where the lesion is. So it's in this way, it will be a very efficient way to point out the problems or the issues or the target, right? So that's our basic concept. So with this concept, you can use it in every kind of surgical procedure, not only for neurosurgical procedures. As long as you have a video of a surgical field, you can use this system.
Yeah, thank you, Professor Chen. And I think this kind of new type communication would be more and more popular, and especially in the very in the emergency case and the difficult case. Yeah,
agreed.
Yes, in third world countries, right, Dr. Ben? It would have more of a use there, you think?
Yes, yes, exactly. Thank you.
Okay, so I think today we have two very interesting presentation, and yeah, thank you everyone for your participation. John, so do you think we should finish?
Yeah, I think that was great. Two great presentations, and I really appreciate it, Dr. Chen. I'd like to invite you, Dr. Chen, to do a separate presentation on neurosurgical TV if you'd like to. So please give me your email address. Okay?
My pleasure. Anytime.
Yeah, our pleasure. I think our community would like to know more about it.
Okay.
So
thank you.
Thanks, Ben, for getting everything together, and Juan Lee. And we'll see you in 2 weeks.
Yes.
Thanks, everybody.
Okay, thank you. Thank you, Charlie.
Thank you.